Okay, good afternoon. We'd like to get started today. First of all, we want to start talking about something a little different. Before case review each time, we want to start where we start to recognize, we talk a lot about stroke and about STEMI care, and we want to start giving follow-up to you guys, especially on the major cases of exactly what's going on. So first of all, this is a 69-year-old male patient with heavy chest pain, became diaphoresis while he was watching television. They followed the chest pain protocol. Then he was transported to UMC. So as part of this, his troponins continued to climb. They elected to take him to the cath lab and put a stent in. As you can see, he has a blockage here in the LAD, and then you can see that it was opened up with one stent. So great job to Aaron Odom and David Lohr, and they have a certificate along with this information on there of exactly what they did. Great job, guys. The next patient we have is a 66-year-old male who was pale, diaphoretic, and short of breath with crushing chest pain in the center mass of his chest. As you can see, the 12 lead was very, very positive with large ST segment changes, reciprocal changes in appropriate leads, just a very large MI that was actually becoming bradycardic. They got him to the hospital very quickly, did everything they were supposed to, including blood pressure support as his blood pressure was extremely low. See, they put 2 stents in to his left descending artery. As you can see, he had 2 different blockages of the RCA there. Once they got both of these open with stents, you had great blood flow. So they did a great job. Got him to the PCI within 24 minutes. Great job, Amanda Miller and Matt Kraft. So very good, guys. Okay, 55-year-old male with severe substernal chest pain. He just had an MI the previous month, and they told him he had a quote-unquote maker. So we know he had a high LAD at some point. The crew did a very good job taking care of him, getting him aspirin, nitro. Now, we think, well, he just got stents. Could this be some of the leftover? It could be, but it's not our job to determine that. And so troponin can stay positive for
really more about a week. Yeah, a week.
So it can extend out. So, you know, if he would have gone into a clinic, his troponin may have still been elevated. We just don't know that. The good thing is our team was very aggressive, 34 minutes getting him opened back up to PCI. As you can see, I couldn't see where his first stents were, nor could I find that. But you can see there's his blockage, and there's once it's opened back up, and they also now prevented him. So Miss Crystal Martin was the paramedic that took care of this young man, and Micah Stone was the ambulance driver on this one. So there's that for you. Great job.
And I'll mention, this is a good thing to remember, that just because you had a stent last week doesn't mean you can't have another heart attack. It can still absolutely happen. This is a drug-eluting stent. The actual stent can still clot back off. Our bodies react differently to things. Or there could be another plaque rupture somewhere else that wasn't real narrowed whenever the patient had the initial PCI, and now that ruptured, it's clotted off. So this happens. So you don't want to just rule it out, say, oh, they had a stent and a heart cath a week ago, so they're good.
So guys, this is the last of the cardiac. I'm going to move over to the neuro side. This was not all of our STEMIs for the month. We ended up having 16 active STEMIs last month. It just took me about an hour for each one of these to go dig this information out. I'm going to try to get better with getting more of these each month, but these were some of the biggest calls that we had for the month as far as activations. So let's move to the neuro side. Now, I had a little bit of a deficit because I haven't spent a lot of time in the cath lab with the new neurointerventionalist yet. I'm hopefully going to get to do that fairly quickly so I can understand a lot more. 70-year-old male was found leaning next to a chair and was unable to speak. That right there has got stroke written all over it, or something's going on with his brain, too much fluid, a bleed. I would probably venture to say bleed at that point. Patient was both positive for a Cincinnati and a band score. They did a great job getting him in. He had TPA within 20 minutes. That is incredible time. And he was in a thrombectomy within 60 minutes, which is incredible. So here's a picture. This is his M1 going to M2, Donnie. So his main vessel's coming up off his carotids. First branch off. This is bifurcation. First branch comes by. This is M1 going into M2 here. And you can see the booger that was in there. Here's his dynamic flow for his entire his entire brain. Once they got him opened up, And you got to understand, this still looks like blockage. Well, the fluid or the dye's already transferred through. This is how much it opened up into his brain. This young man spent 5 days in the hospital and had very, very minimal deficits from a very large CVA that would probably, back before we were this aggressive, probably would have changed his life drastically to where he probably would not have functioned just real well. So very good job to Jeremiah Davis and Angela Lovelace. So here is there. So very good job. All right, so we're going to start trying to do more of these each time. It gives us a chance to be able to see the dynamics of what we were seeing in the field versus what's happened and what's the outcome of our patients. If at any time you have a concern or a question, you can always get with one of the seniors or myself, and we can pull it up on PowerChart and go through it and look at it. Okay, and that's something we're glad to do on a regular basis. All right, so let's move in and start talking about acute traumatic brain injuries. I know we just did a CE over this, the first part of 17, February of 17. We talked a lot about the dynamics of the actual TBI and what's occurring. Now we want to move and start talking about the signs and why we see these signs so we understand what's going on. So some of the things we're going to talk about, we're going to examine the signs and symptoms of the increase in cranial pressure in adult patients, understand what is the cause of these signs, what are common signs, and what it's looking like for that TBI. And then we want to review some cases and some progress notes for this. So this is the case review of wine. It's really good and nice to know that I give nitro with a STEMI. What do I need to know? I need to know the why I give it. That way I understand the systematic approach. So why do we see these particular signs? Why do we use certain medications? And why do we follow the pathways of care that we follow with these? Like I said, we understand we did this early in 17, but we wanted to expand on that just a little bit. So let's talk about something we see a lot of, and it's a funny thing, I see people all the time that go to the emergency room and they say, well, I was in a car wreck 4 days ago and they did a CT scan, they said I'm okay. But today I'm extremely confused, I can't function, I can't put one foot in front of the other, and something's just not right. And we think, well, they had a CT scan, because that's what I think. Oh, they had a CT scan a few days ago, so they're probably okay. You know, their brain's not bleeding. So we're probably out of the clear, you're just having some swelling or something else is going on. But as what starts to happen is we start to have these DAIs, or these diffusal axil injuries. And guys, these are a lot more devastating than we ever thought about. And this is what they're learning about with the NFL, starting to see these guys with big head hits all the time, and they're long-term start to have these issues. So as what part of this is we start to have these bundles of wires, and that is actually a set that's been dissected out from a cadaver and has been colored, and that's what these bundle of wires look like in our brain. Now these are all embedded through, and as what happens is we start to get a shearing motion. So we take a big direct hit, we hit the steering column, Alan punches me in the nose, and then my head goes back and hits the back, the front. Okay, you're supposed to say, no, I wouldn't do that.
I wouldn't.
Okay, that's workplace violence. And so we start thinking about, people that trip and fall. It's just a simple man that grandma walks through the house, she trips and falls, she hits her head. She's got a big goose egg in the front. We think, okay, so what? You got a little bit of a concussion. But as what we're learning is this thing with like shaken baby, this shearing of these bundles start to cause problems for us. And so they're starting to really learn a lot about this deceleration of force, or that spinning motion. Even a simple car wreck, you get hit, T-boned, and start to spin, that actual spinning motion, and what all of this causing inside of our body. So once again, these things are very, very hard to catch. As you can see, this is a repeat CT of a few days after the original CT, and all of a sudden you start seeing these little spots of active bleeding. Remember, anything white on a CT scan typically is fresh blood. It's not old blood, it's fresh blood. Well, what happened, we just did a CT scan a few days ago, is what's happened is about these little bundles, these little wires start to pull and start to tear the little portion out around of the brain matter, the white matter. And so then it starts to bleed a few days later. It's estimated that 50 to 80% of these are missed on a first CT scan. So how many times have you been on that call and you get there and they say, well, I had a CT just a few days ago, I fell. And you think, okay, let's take it to the hospital. It could be a lot more than we're actually thinking of what's going on. So what does this mean to us? The degrees of these vary. Now, if of course, like an NFL player or a boxer, if I'm getting constant abuse, getting hit, or receiving blows to the head, that could be a lot more life-threatening over time. Just because we have a clean CT on it doesn't mean our brain is completely healthy. And as you can see in that repeat CT, they're starting to see those small spots. Now, this is probably a fairly large injury. It was probably a pretty severe concussion to start with. So let's talk about the hemorrhages. So we've talked about the bundles and how those bleed. Let's talk about the rest of our body, the rest of the brain that's bleeding. Hemorrhage is anything. This can be quick onset, which is typically arterial, or a slow onset, which is vascular from the vessel side. And so, or it could be both. You know, it's not uncommon for people to have a subdural epidural hematoma or a subarachnoid epidural. And so we've got to remember our layers, and remember that we start with our skin and we start to move down to our bone, and then we have our dura mater, our arachnoid matter, then our pia mater. And guys, remember those brains, and we're going to try our hardest, if we can make this happen in cadaver lab this year, we'd like to do a head dissection. That way you can see those layers and peeled apart and exactly how tough that dura mater, that tough mother is, because it's absolutely amazing. And then you understand why it doesn't give a lot. So let's talk about the epidural hematomas for just a minute. This is the portion between the skull and just below and before we get to the dura mater. This is where we get the active bleeding in that area. Typically, these are very acute and rapid, so that leads me to believe that it's on the arterial side. It's going to be, and this can even extend down into the brain or the spine area. As we move forward with our subdural hemorrhages, these are vessels. These are our smaller, usually our veins. These are typically going to be slower. This can be in the dura. So remember, as we move on down, we get into the dura or to the subarachnoid area. So these can extend a little bit further down past that. They're past that tough mother portion. And these are the people that fall, and they fall at United and they go home, and we N3 them, and then we go back the next morning, they're dead because they bled very slowly over time. They weren't showing any signs and symptoms immediately. And that's why we want to make sure that we're documenting things like Coumadin use, Paradaxi use, of saying that, hey, I advise them that this is something that you could be bleeding inside and we don't know it. I could advise you that you could possibly die from this, but you don't want to go. And so those things cover us, because what's the next phone call they're going to make? Is to their lawyer and say, well, EMS checked them out, and they said they were just fine, and they sent him home. And then Alan's going to get a call, and he's got to pull the report, and we're hoping that you covered your bases, because what does more people get in trouble for in the state? Documenting refusals and no transports. They get in a lot more trouble than that than do anything else. So make sure we're covering ourselves when we're talking about these. And this could be one of the things that, one of the secondary things that's going to happen after these falls. So our subarachnoid hemorrhages, these are normally pretty acute. This is, once again, from the arachnoid down to the pia mater, so we're getting down to the level of the brain. As you can see, this is a very vascular area here, a lot of vessels in there, and that's going to get direct pressure on the brain from these subarachnoid areas.
You know, we're kind of focusing this discussion on trauma, and all these can occur with trauma, but also remember, so epidural tends to only be trauma, doesn't necessarily all the time. Subdural, you'll often see, if it's not trauma, it'll be the elderly person who's on aspirin and Plavix or Troutman, and they're feeling a little dizzy. We run on those calls, right? And they end up in the CT and they've got a centimeter of subdural hemorrhage. And it's kind of been probably gathering for several weeks, and it just finally gets to the point where there's enough compression that now they're starting to have symptoms from it. And then the subarachnoid, sometimes you'll see that thunderclap headache. It tends to be somebody a little younger, just the worst headache of their life, and they'll have a subarachnoid bleed. So just remember, it's not always trauma.
So what makes it so special? Well, first of all, our brain is different compared to any other organ that we have. We know that. A lot of the factors that come into place, is about, the brain weighs about 2% of our body weight. So it doesn't mean if you're 450 pounds that your brain is just ginormous. So don't think that it makes you any smarter. It's like our lungs. But Here's the unique thing. It requires 15 to 20% of our cardiac output just for our brain. It has no way of any of storage for nutrients and for sugar. And so it has to have it pumped fresh to it. This is why it is so important during cardiac arrest to do the basics, to provide the brain, because it doesn't have anything to live off of. But one other big thing is it's about 10% cerebral spinal fluid. We have 80% brain, and then 10% of blood volume that's circulated through. So and it's a closed vault. That's what gives us the most problems, is anytime I have swelling or a hemorrhage in there, I don't have any open space for it to do this. So what do they do in surgery? They make that open space by doing a flap removal to where they have the room, or they put an ICP bolt in to where they can start monitoring these things. This can...
I was gonna say, we've kind of gotten away from it, but obviously, like here at UMC, we've got a neurosurgeon around, a phone call to right at the bedside. But if you're in, let's just pick your small town hospital, we used to do something called a burr hole, which literally was like an old mechanical drill, and you drill a hole into this. But we've kind of gotten away from that.
It's a hand.
Yeah, it's a hand type.
It's a hand screw.
Like the old-fashioned, like woodworkers thing. Yeah, they've largely gotten away from it. Obviously, you can screw a lot up with that too.
Can we get those on the ambulance?
Yeah. Why not?
Why not? Just do it. So let's talk about ICP a little bit, or intracranial pressures. Typically, our normal intracranial pressure is about 15 millimeters of mercury. So they'll put an ICP bolt in, so as we get swelling, and remember, swelling is not going to happen just always immediately. This may happen over a period of a day or two. And it may be just a simple bleed, but you've got the push, the irritation, and that's going to cause this side to swell, so you've got a lot of different issues through the brain. Cerebral edema, hemorrhaging can cause our ICP to increase. Also, we start talking about decreased blood flow, because then I start losing blood pressure, Cushing's Triad, and we're going to talk some more about that. But we just got to have a good understanding of what that ICP is. So that ICP technically is the amount of pressure applied within this cranial vault that goes across the brain.
And so just remember, obviously, if you have a big bleed in there, just all of a sudden you have increased ICP, right? Because if you just dump several milliliters of blood, there's nowhere for it to go, and it compresses on the brain. You see like a subarachnoid, there's just a tiny bit of blood, but there's a little insult there, or the diffuse axonal injury. Think of it the same way if you kind of twist your ankle. It doesn't swell right that second, right? Usually over the next 24, 48 hours it swells. The brain does the same thing. So you have a subarachnoid, that little bit of blood is not enough to change ICP, but now you have that injury, so that part of the brain swells just like the rest of your body, and then that pops your ICP. So that's usually why that's monitored, and the bolt that he talks about, essentially it's a hole and a little thing that goes in there. It monitors the pressure, and then they actually just drain the fluid off to try to compensate that pressure.
Okay, so ICP is directly related to CPP, or cerebral perfusion pressure. So this is technically, if you think about it, the blood pressure of my brain. Very specific. Now we talk about CPP or coronary pressure, or we also talk about cerebral pressure. Today we're going to use this for the cerebral side. Now the body's automatic system kicks in, and it starts to control and dilate vessels and move things around to make my blood pressure in a good area to where I need to be able to perfuse that. A high ICP though, and what can cause a low CPP. Think about it. If I've got pressure going up inside of my box, in my brain, in my head, and it's pushing pressure, what's it going to do is squeeze down those vessels. That's going to lower the amount of CPP at that point, so we have poor perfusion flow at that time. So we start talking about how do we get CPP? Well, that's MAP minus ICP. Now, everybody can calculate MAP, systolic blood pressure, 2 times the diastolic divided by 3. There's a reason why my blood pressure is going up. It's trying to perfuse something, right? Whether it's my coronary or my cerebral, or if I'm septic, what happens? All my vessels dilate, and I have to try to increase that, so you start dumping epinephrine and norepinephrine in your body trying to close that. This represents the first stage of Cushing's Triad. So I get my CPP going down from pressure. So I've got pressure on the brain from my ICP. It's pushing against the vessels, closing down my flow. So what does my body do? It kicks blood pressure up. So this is the first portion of Cushing's Triad that we see, is the increase in blood pressure and heart rate. But the body says, hold on a minute. I don't know, I can't figure out why you're doing this, what's going on, because I'm showing that everything's registering up here. And so the body tries to come in through the receptors in the top of the aorta, and it starts to say, you know what, we've got to slow this down. We can't have this high blood pressure. So the body starts to kick in on the parasympathetic nervous system side, and this is where we get our second side of Cushing's Triad when we get the bradycardia. So initially, blood pressure shoots up, heart rate shoots up, and then the body says, wait, I can't do this. That's no different than what we do with our protocol, our congestive failure protocol. I add my enalapril. Remember, that's going to slow everything down over time. This increases our increased ICP, also pushes on the vagus nerve. Remember, we have our people that go to the bathroom early in the morning, we find them dead on the pot because they've strained, they've bared down, they've stimulated their vagus, put too much pressure, and it shuts that SA node off. So the third part of the Cushing's Triad moves into the respiratory, the very irregular respiratory pattern. So I have my ICP going up. Now my blood pressure's headed down because my body's trying to fix it. CPP goes down, so I don't have perfusion. Now my brain is starting to starve, and this extends down through the medulla oblongata that's going to control everything, and so I start to have a very irregular respiratory pattern. So how many times have you gotten there and they've got a horrible head injury, their head is mush, and we get there, we start to take care of them, and their heart rate's in the 30s, the 40s, they don't have any blood pressure, and they've got a bad head at this point. This tells you how quick this is. I don't mean stage 1, stage 2, and stage 3. This can all happen very quickly all at one time. I know we can't measure ICP in the field unless we get our little handy drill and a bowl. Not going out there that far.
It's like really difficult. I rotate to the neurosurgical ICU. It's real finicky.
Alan wanted to do it, so I was just asking for him, for a friend.
Yeah, I'll try.
You'll try it. Okay, we're going to try to be first. So we can't measure ICP, but what we can do is we can pick up the signs and symptoms. We can pick up those things and go, I probably got a bad head injury because I'm bradycardic, because where's my blood pressure at? So we get there, we're going to look at some cases here in a minute and start talking about the blood pressure issue, and we're going to kind of put all this together. But remember that our brain has a very high metabolism. It has no storage. So it's going to try its hardest to get perfused. It's going to control everything and say, I've got to be perfused at this point. You've got to give me more pressure. So let's talk about Melvin is their late 50s. This was a car versus pedestrian in a parking lot. And you're thinking, in a parking lot? It ended up being a fairly high speed in a parking lot, and it was pretty much a direct hit. So EMS arrives on scene to find fire and LPD surrounding the patient. He was noted to be combative and had an obvious head injury. The great thing is the paramedic didn't stop there and just say, I've seen those reports that say obvious head injury. Well, what made it obvious? Well, here we go. Does a great job talking about the patient was combative. Talk about there was an open depressed skull area to the left side of the forehead, the dilated pupils, they were non-reactive, and so went into great detail of explaining why the thinking here, the thinking of a obvious head injury. So they roll the patient, throw him on a backboard, move him over, get him, they heart monitor, all that good stuff, and they end up having to take this young man's airway. And once again, the only thing, it appeared that he was going quote unquote fast. So one of the things, he was found once again on the parking lot, talked a lot about the head again, obvious bleeding was controlled at this time, started talking about road rashes, really breaking it down what they were finding, and then talking about our spinal clearance. Cardiac monitor, oxygen, did a great job. Hey, we got him on a cannula pretty quickly, got an IV in place, got lidocaine bolus. So we're going to talk a little bit more about lidocaine here in just a minute and why and the why nots. But this was due to the patient having a head injury, which is our protocol. They also added etomidate. Is etomidate the best drug here? What's your thoughts? Yeah, why? BP, you're shaking your head. What's ketamine going to do? It could raise his pressure, but it's not contraindicated. So we can use either drug here. So you just got to think about these processes. They add succinylcholine in. Suctioned him real good because he had blood in his airway. They got him intubated very quickly. Did a very nice job managing him. So First set of vital signs doesn't have a blood pressure. Is that blood pressure going to kill him? No, but that airway is. So they were taking care of the things that had to be taken care of first. Got end titles on him at 40. That's within normal limits. That's probably pretty good. We're looking great right here. First set of vital signs, 116/81. Heart rate was 78 and saturations were 99, being ventilated. Here's what they found, the CT scan. Ended up having an epidural hematoma, extra-axillary hematoma, subarachnoid, an acute subarachnoid, and then had the skull, the base, the fractures in the face, all the way through the left coronary canal. So left occipital, left orbit was fractured, but the globe was intact. So he had a lot of head injury at that point, a lot of things going on. Now, we start thinking about this blood pressure, and we're thinking, what are we thinking at this point with a 116/81? If I could get to 116/81 on a daily basis, that would be great for me. But I can't, even on blood pressure medicine. But for a head injury, is this good? No, it's not, because he needs the perfusion at that point, right? He needs to push it. Here's a look at his CT scan. That was a look all the way through the CT scan, okay? Bleeding in the very core in the middle, center. That's a very bad spot, not doing good at this point. But the fortunate thing is there was no fractures in the spine. That's good in his C-spine. The intratracheal is in an appropriate place. But they did find some fractures, some dislocations in T10, T11, then going down to the posterior body of the T12 was injured and dislocated. So the treatment long-term was diagnosed with they took him to a cerebral angiogram, looked at his angio flow, and started the process by fixing his thoracic spine. As you can see, there's a picture of the T-spine. Treatment and outcome, he remained in ICU for 20 days. He was intubated on a ventilator for about a week. He started going into multi-organ dysfunction syndrome, which was not good, but he ended up being successfully treated by all of that. They got all of his organs going again. He was discharged to inpatient, alert and oriented ×3, mildly confused. I would consider that very good after reading everything that was wrong with him. Ventilator support, no ventilator support was needed, but a trach was needed, so he was breathing on his own, able to be discharged. Ambulatory with mild unsteady gait, which he may have for a lengthy period of time, maybe for the rest of his life, who knows. But so they did a very good job taking his airway quickly, providing oxygen, managing his end titles, and keeping his head up. So let's talk about the lidocaine thing for a little bit, because many years it's been, we're going to give lidocaine, we're not going to give lidocaine. Why do we give lidocaine? You know, some people say it's good, some people say it's bad. Lidocaine helps us out with a lot of the fluctuation, the systematic approach to the intubation. You know, for a long time it said, well, lidocaine helps bind to the CO2 in the brain and helps pull it off from that point. That's still questionable if that does work, but is what it does allow us to do is it allows us to manage the gag reflex and the coughing, which is going to increase our ICP. So let's talk about a study real quick. 97 head injury patients on London's helicopter that was intubated following a significant head injury. As what they saw is an average of the heart rate increased 22 points, the systolic went up 42 points, and the mean arterial pressure went up 30 points. You can't afford that. What happens when that mean arterial pressure goes up? My bleeding gets worse. It can possibly increase that head injury. And so we need to make sure that we're managing those systems as good as we can. So lidocaine, is it effective? It is not. It is still on the fence, but what it does do is it blunts the coughing and the gag reflex, which increases our ICP. That is it. How many times have you gotten there, you know, and you've tried it, you think, well, they're down far enough, I can tube them, you put the blade in, and they gag real quick. Their ICP went through the roof when we did that. One of the other things is during intratracheal suction and cough suppressant, this can help us out. Now the thing is, we know that it takes the lidocaine a little bit of time to kick in, about 2 minutes or so. So as I'm getting stuff set up in the back of the truck, get the lidocaine on board as soon as you can and then draw your other drugs up. I see it all the time. You'll see lidocaine given, and 20 seconds later they're given ketamine or etomidate. Make sure you get that lidocaine on board and give it time to kick in and start to work these effects. So other ways we can help, first of all, be gentle with the airway. Y'all seen somebody sometime in your career with a blade in, and you think they're going to rip their trachea out from down in the throat, because I mean they're bearing down hard. Be very gentle when we go in. Try to keep it down to 1 attempt. I know we always try to keep it to 1 attempt, but really fight for that intubation as soon as we can. Airway positioning to facilitate oxygenation. Remember that any drop in oxygenation, any increase in blood pressure spike, or increase in CO2 or drop in CO2 increases mortality. So I need to be very aggressive with making sure these people are oxygenated. Now, what happened before I got there? I don't know. And so is that my fault? No, it's not. But once I assume that patient, assume care of them, I want to make sure that I'm providing great oxygen quickly to them. Pre-oxygenate them before and during intubation. I don't know how many times I've seen with that nasal cannula on, very few drops in blood pressure or in oxygenation anymore. It works very good with passive oxygenation in place. You're providing that oxygen, and once again, that does increase your mortality.
Although, did you see there was a study that came out and said it didn't help?
Yeah, I saw that the other day.
I still think the argument is it's no big deal to do. It wasn't a statistically significant difference, so I think we should still be doing it.
Yeah. So let's talk about vomiting real quick. How many times you got there and that head injury's laying there and just projectile vomiting and you can't stop it? You know, the fountain of Vesuvius, you're trying to suction. You got 2 suctions going, you can't get it cleaned out. So what causes that? Why? Well, first of all, the floor of the first ventricle at right here at the base of the skull. This is what triggers our chemoreceptor there to cause us to have emesis or to vomit. The thing we have to remember is every time we have emesis, this increases my ICP. Anytime I'm straining, now, is there anything I can do about it immediately? Absolutely not, besides paralyze them. Zofran's probably not going to help you a lot on somebody who's in that bad a shape. Once again, at the floor of the fourth ventricle, this is where it controls our dopamine, our serotonin, our factor P, our substance P, our opioid, and our acetylcholine receptors. And so this is where it starts to really say, hey, let's vomit. It's time to vomit now, and this is where that gets triggered. So this is a lot of times where when I'm pushing the opiate, I push that morphine, that fentanyl, and they get nauseated quickly. And so this is where that's driven from.
Chad,
Sir?
would it be better to use like a long-term paralytic so that they don't buck and do things like that after intubation as opposed to sucks? Or
My 2 cents, if you got them sedated, if you keep them down sedated, you're better off that way. You don't want to re-paralyze them, you don't have to, but.
It tends to be so I think your theory is exactly right. Anything, whether you're dealing with a neurologist or in this case, usually a neurosurgeon, they want to try to see what the patient's doing. So you delay that exam for them because they want to know, was this patient decorticate, or as they try to lay off the versed or something, are they trying to wake up normally? Maybe should we pull the tube? Should we leave it? So that's why I think usually pre-hospital and even emergency medicine, if it's neuro anything, we want to use short acting so then our consultant can more evaluate the patient. Because it can dictate, well, we're going to take this patient to OR right now and cut a window, or maybe let's wait and put a bolt in and watch their ICP. So we take that away for an hour, essentially long acting.
yeah.
If you have to,
Yeah, if you got to, you got to.
use it.
But the
Hopefully-
neurosurgeon will fuss.
Yeah, they're gonna fuss. They call me fuss, but it's okay. So nausea and vomiting, let's talk about the intracranial pressure is increasing. The pressure may be directly related to the small brain vagus nerve. It's right there in the gold. So as you can see, as they're vomiting, we've got pressure, they're straining, that can stimulate that. The acetylcholine in the neurotransmitter of the vagus nerve hits the parasympathetic response, and that fires off into the SA node. We get some bradycardia, we can get a lot of different issues with that. So once again, vomiting is spiked by increase in ICP, whether it be just a concussion. Now I start to get some swelling. So this could be our kid from Friday night that we pick him up Saturday morning, and they said he's thrown up all night. What's happened to our intracranial pressure all night? It keeps spiking and go down, spiking and go down. So through our TBI, we want to make sure that we're trying to treat these guys as soon as possible because vomiting can extend that brain injury, and we want to make sure that we're trying to take care of them. That may be the simplest thing of giving some Zofran to that patient who just needs a little bit of help getting through. So other signs that we're going to be looking for, once again, is a change in pupillary response. And it's something everybody's going to pick up on quickly. You got that blown pupil that's non-reactive on one side. I'm going to really kick off on, hey, I've got something bad going on in my brain. So why? What causes that? Well, anytime we have the pressure on inside the brain, we get pressure in the box, we push down, and we hit our cranial nerve 3, which affects our pupillary constriction. And it also affects the branches, once again, the vagus nerve. Pupillary response is directly related to the CN3. There's a good picture of a blown pupil or dilated pupil that you're going to see. Typically, most of the time, we're only going to see one side affected. Probably some of you have seen where they got both sides blown. We've got a big bad problem there because we have both sides affected and there's a lot of pressure. So this young man was in his early 60s. He fell out of the back of an 18-wheeler, but he says he felt woozy. He began to vomit, so we know we have ICP growing. We also have a history of hypertension, so is he compliant? He's a diabetic as well. How many of those people, we start to weigh this and start thinking, but he fell out of the top of the 18-wheeler, fell back and hit his head. So we got the spinal precautions, we got cardiac monitor in place, and then his first blood pressure. 254 over 150. Okay, that's a mean arterial pressure of about 184, give or take a little bit. That's an astronomically high number. What's his heart rate? His heart rate's not causing it. He's not trying to compensate by kicking his pressure up by his heart rate. You can see his glucose is a little bit elevated, which may not be, that's just stress of the body. It could be, but he is also a diabetic. He's alert and oriented, but he's very nauseous and dizzy. Pain to the head, no active bleeding. This is one of these we need to be extremely aggressive with our Zofran and get that Zofran in as soon as possible and trying to prevent that any further vomiting. So he did a great job getting an IV, got the Zofran on board, projectile emesis. Pressure now 240 over 140. That's still an extremely high. It's probably mean arterial pressure of about 158-ish, 156. That's still extremely high. They say a bad head needs a mean arterial pressure between 90 and 110. He's still running in the 150 range. That's extremely high. But he remains alert, he remains oriented. He is confused with some questioning, which may not be too uncommon at this point. Conscious, alert, and oriented at GCS of 15, but still vomiting. CT of the head showed a subarachnoid hemorrhage to the right temporal and parietal lobes. No midline shift or herniation. There was no spinal fractures in place.
So do you have no cranial fractures?
Nope, no cranial fracture. We wish he did. Might help relieve a little bit of that pressure. But there's a picture of there's the CT, there's the small bleed right there. I say small bleed, but I mean, that's really not that significant of a bleed, but there's no midline shift, so he's still doing pretty good. So what happened to him? His heart rate consistently stayed low in the 50s and then dipped down into the 30s, the high 30s for the first little bit, 3 days. And then it increased back into the 80s and he was able to walk down the hallway. Patient continued to have persistent nausea, so this can be persistent. This is why sometimes we see even a week out, they said, well, he has a concussion a week ago, he's still nauseated. Take it, okay? He's still suffering from those signs and symptoms. They went ahead and worked him up on a stress test, ejection fracture 53%, which is almost 60-ish. And so it's still a fairly good ejection fracture, so they said that's not the cause of the syncope. He was in the hospital for 6 days with no worsening, and he was finally transferred out to a rehab facility at his home city and was monitored on the Holter monitor for 4 weeks. So he'd had a pretty decent outcome. Guys, as part of this, after a case review, we're going to start to kind of review one skill that we do, try to do this more on a monthly basis. So let's talk about the IO real quick. Remember, our contraindication for this is fracture to the targeted bone that we're going for. Now, does that mean a fracture up here? Yes or no? If I've got a fractured femur, do I want to start an IO? No. Okay, if at all possible, no. You don't want to do that. Previous or significant orthopedic injuries, and we're going to talk a little bit about that. An IO in the same spot for the past 48 hours. We had a guy go into arrest, and we picked him up. They transferred him to the hospital, let him out like 40 hours later. He went back into arrest at his house. So this can happen from time to time. We got to be careful. Infection of the inserted area. If I have cellulitis in that leg, I don't want to stick that through there, that needle. It's going to get all on there, get into the bone. We could have osteomyelitis. You get a lot of different issues with that. Excessive tissue, or we're unable to find the landmarks. Now, we have a little bit of variance here because we have a larger needle now that we can use on some of our larger patients. So there's a good picture. So why not on a knee replacement? Well, here's why. It's all titanium in there. Guys, we have had one of these that got documented and didn't go so well. They hit that and wow, it didn't go so hot. But that's one of those things that we need to pay attention to our scars on our knees. And
these are usually pretty obvious scars, right?
Yeah.
If you've had a knee replacement, your knee's just been butchered.
Flayed all the way open. So on our adults, we're going to find the bottom of the patella. We're going to go 2 finger spaces from the tibial, looking for the tibial tuberosity or the flat part. Mine is really easy to find. Go ahead before y'all start. Really easy to find on the chicken legs. On our infants or our kids, we're going to remember we have a growth plate built in, so we need to be very diligent with how we're putting them in. 1 finger space past the patella to the medial aspect of the tibial tuberosity and get those in place. Humeral. Now, guys, this is something we don't do a lot of here, but we were thinking, well, this could give us some more options. The needle has given us a lot more options, but not necessarily in the humeral. So it's what's happened. Remember, I got to pull the arm across during cardiac arrest. This doesn't go real well of keeping that arm here. We talked about that in last cadaver lab, and we'll dissect the arm down again this one, so you can see that that medial rotation the anterior rotation of that of what we're going for. These patients need to be older. They need to be about 40 kilos or 88 pounds or bigger. We want to rotate the arm toward the abdomen. The IV site is the lateral aspect of the humerus, 2 centimeters distal to greater tuberosity. So we're going to rotate in. We've got to find our nice flat area. We're going to rotate in. Okay, and so we're going to be, remember, not on top of the shoulder, but we're going to be rolling down. The 45 millimeter needle is going to be used. Remember, I've got to stick it in. I've got to be able to see a black line to know that I have enough needle left in order to stick it in all the way into the spot. Post management, you're going to find out really quickly if your patient is fully unresponsive. You start to push fluid through these, it gets very uncomfortable for them. A lot of nerve endings inside of the bone. We're going to infuse the lidocaine 2%, 1 milligram per kilogram to a max of 50 on adults and 40 on our pediatric. But we need to also remember, and it sometimes may take up to 60 seconds for this to work, but our contraindication is allergy to lidocaine, bradycardia, or any type of a heart block. Remember, what do we use our lidocaine for? Antiarrhythmics. It is going to sodium blockade. It will start to slow things down. So if you're in a bradycardic rate, you're going to make things very, very much so worse for you and for your patient.
So does it hurt whenever you put in an IO? So interesting enough, if you go, this is a physician that developed the Easy IO, and he actually has YouTube videos of him putting it on himself. I think you'd have to be high on something to do that. But they say it doesn't really hurt going in. They say what really hurts though is when fluid comes in. That's why we don't inject lidocaine first and put it in. We put it in and inject the fluid or inject the lidocaine. Has anyone ever tried to pull out an appropriately placed IO? They are tough. Whenever they're in there trying to pull one out, it's tough. It usually involves somebody holding the leg down, somebody pretty good pulling on it. Even sometimes we've taken pliers in the ER trying to yank one of those things out. So just a couple things on that first case. I know the patient was on the backboard. We're trying to minimize that use. There's a study out there that shows our intubation success rate's a little lower when a patient's on a backboard. So don't forget, we could have considered removing that from the backboard. We didn't have any issue, we still got the intubation, so all was good. Lidocaine and head injury, Chad covered that pretty well. You know, neurosurgery here supports it, some places they don't. I think most places do though, because the studies haven't showed a lot of benefit, but no study has shown that it hurts things. So it's one of those things, we do it, and you know what, if it helps 1 out of 100, that was 1 out of 100 that helped. It's cheap and it's easy to give, but the biggest issue is, I think you mentioned, is you don't just push it then start pushing your RSI medications. It's supposed to soak in for a couple minutes. I think you mentioned give it and get the rest of your stuff ready. So I think that is the right way to go about that. I made a few other notes. Ketamine and head injury. A lot of neurosurgeons are very against that. They feel like it increases ICP, but there's been data that shows that it doesn't. So, you know, I think etomidate or ketamine, either one is an appropriate response or appropriate drug. I don't think we've had issues here with neurosurgeons fussing about that. So also that first case, so we talked about that head, it had some obvious fractures we felt like, right? There was a depressed skull fracture. So just remember, because I know we documented that we controlled bleeding. Obviously we want to be careful because if we have exposed brain or we think it's kind of mushy up there and we put a lot of pressure, what are we doing to ICP? Increasing it, right? So obviously you kind of get this dance on it. If it's just pouring blood, we want to stop the bleeding, but we don't want to put so much pressure that we're increasing ICP. So that's just something to think about. The other one, and I'd love to look more at the chart on that second patient, because what I'd like to say, if you see blood coming from the ear, what does that typically mean? It probably means one of two things. Either there's a fracture of the skull, because how else does blood get out, or literally the person fell on a pencil or something and actually has an injury inside the canal. Now that can happen, but that's a lot more rare, right? This person fell from several feet out of an 18-wheeler, he hit his head. Now the thing is, a lot of times the initial CT scan won't see a fracture, and you'll tend to see, and I bet if we looked in this chart, probably within a few days later, they do a thin cut to the temporal bone, and there will be a little minute fracture there. It's kind of clinically insignificant. They don't go in and screw it together and put a plate, it just kind of heals back up. That's all I have about cases. So hopefully you don't throw tomatoes at me. Hopefully everybody reads their emails like 10 times a day, right? It's all the email that I sent out about cot, airway bag, cardiac monitor on all calls. And I know through the last several years, we've kind of changed various ways on how we go about this. I've kind of fought it myself and not really wanted to support taking everything all the time, because like many of you would probably tell me, it's stupid. Why do I need to take an airway bag or a heart monitor when it's supposedly a stubbed toe? But I think the reality is, you know, that's what a high functioning service, you take the tools, you're there, your tools are there, you throw everything on the cot and you go to the patient, you've got everything right there. And I think it's a very little bit to ask for the potential, because we've all went in on calls, we've had to review calls that we end up in there and it was an arrest or something, we didn't have a monitor, we look bad, plus we don't give the best care of the patient. So hopefully you won't be too mad at me for asking that. I think it's really what's best for patients. Y'all have any questions?